Evening to our Indian colleagues and good morning here from New York. And let's see, everybody can hear me?
Yeah, we can hear you. Good morning.
Oh, good. Good morning. So I have Dr. Srinivasa Rao and Dr. Narasa Raju.
Yes, that's right.
Both of you are there. Good, beautiful. So we'll get on to it. Welcome from Mount Sinai Cath Lab, and we are going to start a case which is sponsored by our son Pharma. That's the case number 18 in our series of live cases from Mount Sinai. And if everything is okay, we will have a lot of discussion. So we'll start with our case. These are myself and Dr. Keeney, and of course both of you. I'm so happy you to be a part of today's webcast as a faculty and the moderator. As here, Dr. Srinivasa Rao Madurai is the head department of cardiology and senior interventional cardiologist at Apollo Hospital, Hyderabad. Very well accomplished, multiple trials, great name, and we have met quite times in our various meetings. So hello to Dr. Rao from Mount Sinai, myself and Dr. Keeney.
Good morning.
Good morning. And then Dr. Narasa Raju Kawalpati is the director of the Cath Lab and senior interventional cardiologist at Apollo Hospital, Hyderabad. Very well accomplished, I would call it a budding interventionist. And welcome to our this month's live case presentation. And then we'll have the case you'll be discussing with the trifurcation circumflex along with the moderated discussion and interactive panel later. So with that note, the case number 18 is a 42-year-old male who presented with new onset angina class few months ago after CTA revealing multi-vessel soft plaques. High calcium score, but they called it the plaques were soft, non-calcified, 3-vessel, and patient was no CAD before, has some hypertension, hyperlipidemia, ex-smoker, positive family history. There was some question about aspirin allergy and SAQ. SAQ is basically the representation of Canadian class kind of symptoms, and any from 0 to 100, as you know, towards 100 is better, minimal symptoms, and 0 means very significant symptoms. Patient was on 2 medication, amlodipine and metoprolol and torvastatin, and then was added prasugrel 10 milligram because of aspirin allergy last time after the PCI. The cath which was done on February 25th revealed 3-vessel disease, and Anu is going to show that of the 2 were taken care, and today patient is for the 3rd vessel. So we can go to the angiogram first.
Show the angiogram.
Yep.
So this is the left system. Left vein is non-obstructive, and circumflex where we stented. The stent looks good. Large size LPL, small OMs. And this is where we are today with LAD. So prox LAD is okay. Then you have mid LAD about moderate disease, and distal LAD, which is actually after the 2 diagonals that has taken origin, again 80-90%. Then you see tandem lesion. Then there is a small gap, and then you see which looks like a bridge, but the bridge is significant. D1 has a 90-95 lesion and is about 2.2 size vessel. This is the LV gram, which is normal, and RC also where we did the stent looks fine.
And look at this. I mean, I'm surprised that they read a calcium. It was done outside. Calcium 1001. Once your calcium 1001, you definitely see heavy tram track calcium in the vessel. So my question is, maybe it was supposed to be 101 rather than 1001, right? You agree with that? Because once you get 1000 calcium, it's a very high calcium score. And even LAD, they did read the plaques were soft. And that's exactly we have. Non-calcific plaques in all 3 vessels, but and syntax score was 22. And if I have to just go back to slides again, so I present, and then we'll come back to the discussion how to tackle this case. So today is now patient then, the question about allergy, went to allergy specialist, they said no problem, give aspirin, desensitize, and patient got aspirin today. Now we know that in the past we used to desensitize these patients quite a bit, but now since the advent of ticagrelor and prasugrel, where aspirin can be eliminated. Remember, those trials are being done whether minimal or short duration of aspirin or maybe no aspirin. Could be escort trials with the prasugrel and with the various trials of with the ticagrelor aspirin duration to be 1 month or even lower. With Global Freedom and Twilight was 3 months. So key is that we did prasugrel last time, but now they're given 81 milligram, which is 75 equivalent in India from aspirin point of view. And now we plan for multiple PCI lesions of the LAD diagonal, and we'll come back to it and we'll take a discussion from everyone. We say that this one will be FFR guided because there is no physiological testing done. So just to update, FFR in terms of we have been waiting quite a bit. The recent JAC and AHA and ACC and SKY all came with the guidelines of our coronary revascularization, and FFR has become class 1. There used to be in European, but in United States were not there. I mean, now we have the class 1 indication of both, and they put both FFR and IFR. They have not done the other resting parameters, RFRs and others, but both FFR and IFR because of various comparative trial has made as a class 1. Now, once you decide lesion assessment, with the IVUS, and so it is 2A. As you see, OCT is not for lesion assessment. They do have a OCT as a post, but pre, you cannot decide the lesion because it's not clear what should be the lesion assessment, what is the degree of stenosis on the IVUS or MLA. The recent favor trial comparing, they did on IVUS, the MLA of 3 millimeter, and if it is between 3 and 4, you need a plaque burden of more than 70%. So anything between 3 to 4 millimeter square MLA is considered as significant on the IVUS. So, but it still remains 2A because we don't have a long-term data on that. The second point was still that hard team approach and calculation of both STS and syntax score, and also use some frailty indexes like cirrhosis, frailty, malnutrition. So besides just looking at the scores, you need to take care of other points also in the discussion in these patients when you present. The other important was that what improves survival. And survival, basically, you remember the multivessel disease and cabbage has been a prime, the class 1 indication. And here it actually has been challenged quite a bit. Largely because of various data also have come up with the PCI and no convincing that many subgroups of the cabbage really improve survival. So if you take it in a simpler way, the green bar, that if you have a multivessel CAD, as you can see there, and left main disease, that patient is good for cabbage. The second group will be patients who have multivessel disease and the EF, which is in the center, less than 35%. So those are the two groups now has class 1 indication. So there is a lot of back and forth discussion in the various letter to the editors and so that why this downgraded of the cabbage occurred. But that I would say the real life situation that because, and PCI has moved up to many 2A categories which used to be class 1 for the cabbage in the past. So very, very important. And also this is for basically survival. Now for symptoms is different. As you can see right on the top, you have stable disease, patient has angina, yes, for symptom improvement, PCI, cabbage, whatever needed is can be done. Now also, they actually had not included much in terms of various syntax grade, low, intermediate or high. So they do mention, but the syntax really high grading or so has not been part of the equation. Now this is basically the radial versus femoral approach. They're making clearly class 1 now. Radial for ACS to decrease mortality and vascular complication or bleeding, and class 1 also in stable disease to decrease the vascular complication. So this is where come from various trials. And the IVUS, because they still don't have much long-term, although I think there is enough data now on long-term IVUS decreasing mortality, but still they are not made it to class 1. So both IVUS as well as OCT, they made a OCT also as a 2A. So first time OCT has come into equation, and IVUS that particularly in patient with a left main or complex CAD. to reduce ischemic events. They did not make mortality yet because you need a multi-center long-term trials to answer that question. And then, of course, once patient comes back for ISR, you should do the imaging that has been emphasized further. Then from complexity point of view, they say that once you have complex disease, you need to do revascularize these patients. Wait and watch on medical therapy is not good. So this where we come down to that your total occlusions, high syntax score, patient does not qualify for one of the other criteria of the CABG or PCI, but something should be done to this complex disease patient because awesome trial and others showed that medical therapy alone have a very high mortality. And optimum trial recently CABG turned down showed that very high mortality of those patients. So something should be done to them. Very, very important. Then patient with diabetes. So they did mention that patient with a multi-vessel CAD, if you have involvement of the LAD, then it's a class 1 indication. Others is still 2A for PCI. Multi-vessel CAD, PCI is became 2A, no longer contraindication. And same thing for the patient with a left main or lower intermediate complexity of the CAD, the PCI is class 2B. So with that note, I think we'll have a lot of other discussion. Go back to the angiogram and let's hear from our faculty and moderators that how would they deal with this lesion, and would you just go ahead and do the intervention or will modify based on the imaging study, knowing that this patient did not have any stress test and show.
For me, I just want to ask a question before we begin, Angio. See, we have Twilight trial which showed that when you are trying to do with the complex angioplasty and stenting, even with the endovascular ACS, they did show that if you eliminate aspirin, it is not going to do any harm.
Yeah.
So when you have this kind of patient where aspirin is allergy, questionable allergy, do you think that it was good to use in the place of prosecutor a ticagrelor?
Yeah. So this we actually have personal lot of experience now. Single monotherapy of prasugrel or ticagrelor. Can I say it for clopidogrel? Probably not with that confidence, but I'll have no hesitation in doing a left main bifurcation intervention and discharging patient on ticagrelor or prasugrel single monotherapy.
His question is, why prasugrel, why not ticagrelor based on the Twilight?
Yeah, no, that's could be both.
Answer,
but remember, the one question was Twilight and Global Freedom were 1 month and 3 month aspirin.
Global Freedom.
Yeah, nobody took out at time 0. But we have the Ascent trial, where there prasugrel aspirin was given at the time, and then they starting the second part that no aspirin at all, right from the day 1. So we do not have clear cut the Twilight point of view, but with the same token that taking away aspirin in these cases is completely fine, in my opinion, as long as you have done the good job angiographically, and particularly if you have really supported by imaging. So any one of them, I would say I have no objection to one versus other. And Anu, you did give a prasugrel, any particular region maybe? You can answer, but I would say that any one of them, we actually are very big on prasugrel in our lab. I know some ISAR React 5 did favor prasugrel. We did our own experience in our large series of cases. We didn't find those kind of differences which was in ISAR React 5, but we have been using prasugrel way more than ticagrelor in our lab, particularly in patients with stable CAD.
Okay, so here, what can we discuss?
Yeah, let's discuss this case now. That question is that do we need to worry? I mean, physiologically, if we have to get, and maybe we can ask our viewers to put in the questions and their comments in the chat box, that what I want to do is clearly the distal lesion of the mid to distal lesion of the LAD, which is 90+%. We know by various data that will be positive FFR. But what if we take it to the D2 and whether that LAD lesions, they will be significant or not? So that's where the question. What do you think? And we can ask our audience also.
Yeah. So I think the LAD lesion, which is, the distal part where lesion looks very significant, but the amount of area it's supplying is very limited. Yeah. So rather the diagonal looks very big at that particular place rather than the LAD main vessel. It's tapping into a very small vessel. If it looks as angiographically, the last diagonal looks to be much bigger than the LAD, which is seen here. Yeah. We think that we need to do any kind of intervention for the distalmost part of the LAD? Is it going to really help?
Yeah. So it's a very good point. So what you're basically saying that leave even the distal LAD alone and just take care of the proximal, those two segments of the mid LAD, which is supplying basically the second diagonal. So we equalize. So right now our wire is, I'm so sorry, there is a little issue with our the hemodynamics.
No, we can't show. Don't move the cameras.
They can move the camera or no?
There's no camera that will move.
So, okay, equalize. Now let's go.
Done, right?
So this is, we are using the FFR. I know a lot of people use IFR. We in our lab actually we do a FFR or imaging guided intervention in 62% of cases. So that we are very big on the, not much deciding on the imaging. I mean, not with the anatomical, but more physiological. And of that, 85% is FFR and about 15% is IFR. And IFR basically patient with asthma or patient with a valve disease, particularly aortic stenosis, where do not want to give the adenosine. Okay, so we are going to start the drug. Yeah, if we need to, let's say, we need to. We actually don't need to. It's already 0.8. Yeah. 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 It's a 0.8. So it's significant.
0.80, yeah.
Yeah. We stop it. Don't start any drug.
Yeah.
Yeah. So this is the resting of FFR. Yeah, we're done. Yeah. A resting FFR is already positive. So that LED lesion is significant. So let's discuss about pro and cons of this. Yeah. Huh?
How did you do that?
Oh,
that camera.
There's camera.
Okay, fine, good. Fine. Okay, now I'll use run through wire. Okay, I'm going to pull back.
Yeah.
Pull back.
And we are doing the pull back now.
Okay, no drift.
IFR definitely maybe a little more precise in terms of localizing, and FFR, but same. They actually had not mentioned because of various data that post PCI physiological indices. So they're not part of the recommendation. And we know that many trials actually have looked into this aspect and it's still very questionable. Questionable in the sense that no matter what you do, focal occurs in about 25% of cases, focal lesion causing abnormal IFR or FFR. Mostly is the diffuse. And you just cannot do about it. You can put more stents.
515
in the focal, yes, you can always optimize. But in the distal, once it is diffuse, it always remains the issue. So now the question is, can we simply go through? Because remember the lesion is there in that diagonal. I mean LED just before the second diagonal. And then if we, and that LED, yes, clearly diagonal is bigger than LED, but still. Remember that goes to the septum and supplies the apex. So if we can go easily, to me, I think it's no disease in the second diagonal. I think will not be wrong. Just put a stent from the distal LED to the mid and keep the diagonal, whether you shoot a wire or not. That also part of the lot of discussion, whether jailing wire or not jailing the wire. What balloon you want? 2.5?
2.515.
Yeah, 2.5. Yeah. Okay, no, so we were able to put a wire
long stent, one long stent versus...
Yeah. No, two stents. One across the second diagonal and one proximally.
Okay.
At that time, we had to do the lesion in the D1.
Yes.
All right, guys, keep telling us what else you will do differently or any points of discussion or any other questions by our audience. So let's find out. Maybe a chat box we can ask our audience that would they take care of the distal LED or leave it alone and just take care of the mid LED to the second diagonal, right? I think that's a good question to ask. Okay, this is a 2.515 balloon.
Yes. Okay.
Okay, going on.
Go. Okay, down.
Good. In the end, you want to do some imaging?
Down.
Yeah, it's a moving. 15 always.
Means not moving.
angle.
Little calcium there.
Yeah.
There's
Okay.
calcium even in the mid LED. If you see that, it's a speck
So
of calcium.
you want to
Okay,
do
go up.
IVUS ready? Get the IVUS
No,
ready.
no,
If the calcium they said, we
No,
can
not
look
yet.
into it.
No,
Yeah.
What do you think? You think it's a calcified lesion?
no, we're doing image.
Huh?
No imaging.
I'm sorry, what?
We're not doing imaging. That's okay.
Okay.
Okay, take a picture.
Okay.
No. Don't open. Kiski.
Yeah.
No. AK said no.
Yeah. There is another lesion very distal, which is a bridge.
Yeah,
So that can be left alone.
Yeah.
It's opened up.
Yeah. And LED is good size. Look at that now, right? So glad that we made a decision about that. So let's do one stent there. And then we do a second stent in the...
AK said no.
Okay. What stent you want? 2.5?
Use a Promus earlier. So Synergy or Promus, whichever way you want. Yeah.
Okay. You want to put a 28?
2.5, 24.
No.
24. 24
Are
and
you
then
giving
you
a
do...
gap?
No gap. And then you put a 3.5 in the mean.
Okay, 2.5, 24.
Yeah. Yep. Now, would you protect the second diagonal, right? That's a big question. Would you wire the second diagonal?
I think it's better to actually protect this, although that doesn't look any disease at the...
Yeah, still there is no disease. Yeah. So, I mean, lot of people will, the data we recently presented, we just paper in JACC intervention, the side wiring of the jail, jail side branch, the wiring or side branch protection. And overall message was that it does not make difference unless your side branch was more than 70% or 65% involved. So like this particular case, overall, if you take all the cases together, it was no difference. So it was only if a lesion was more than 10 millimeter, as well as it's more than 60% obstruction of the side branch, then wiring the side branch will be was beneficial. But otherwise, as a group, was not different.
How about the angle that it's taking off? If the angle is very,
Yeah,
acute.
actually, you know what? In that
Proper.
study,
Yeah,
you want to pull back?
angle did not. Yeah,
Yeah,
go.
did not make a difference. You need to pull back.
I'll go back. Hold on. Okay.
Huh?
Now you're good.
You're good? Because we cannot be overlapping at the diagonal level.
Yeah. You're good now. No?
You have to bring 1 millimeter back. Because remember, Promus, the stent starts inside the dot.
So I wanted 28. Okay.
Good? You're going on?
Okay.
You want to see again?
Okay, go.
Okay, go up. It's a 2.5, 24 Promus Elite. Yep.
Go up again.
So both we use a Promus and Synergy.
Down.
Quite a bit. So use your last time 2 Promus stents compared to Synergy. You want to tell our audience that why? A lot of people here, let's dilate this area with the balloon now.
Yeah, but I am good.
Okay. Guide is sucking in, so make sure
Because
guide
it's
is
a
out a little
significant
bit.
disease. Yeah.
Yeah.
Okay.
Go on. And with the second one, we are going to wire the diagonal. Because diagonal, there is a gap. There is no osteal involvement. So we can just put a separate stent. You can go a little higher pressure there. 18, 20. Good.
You want to stent D1?
Yeah. So we do
2
a
or
what
12?
balloon?
And
Or
then we
cutting
put a
balloon?
2 to 5,
2.2.
16.
Or get a 2.25 cutting balloon. Okay.
Okay. Ready?
Yep. Okay, we are taking a picture now.
Okay. Looks good. He wants a cutting balloon. Why? There's nothing there. It's not in the ostium.
Yeah, that's fine. 2 or 2.25 cutting balloon. Now you just or get a high pressure. That's fine. You can get a high pressure balloon. Which size?
2 to 5.
2.25. 12 high pressure balloon.
Yes.
So we are going to wire the diagonal now.
D1.
D1, not the D2. D2 remain good. Look at that. Everybody agrees? Like D2 still remain fine.
Yeah, it's well open actually. No
Yeah.
plastic.
No issues at all. And the question will come that the D1, since the osteal involvement is not there, let's keep it away from the ostium rather than doing a mini crush or so. And there also you can come just there at the ostium, for the main LED stent. You may not need to go across. Although if you need to go across, that's not an issue also. Now, what do you like to do? What would you do being there? You across or just at the distal edge?
Which one?
Or the mid LED?
No, I think we not across.
Yeah.
We'll
Okay.
give, yeah. So that's why we'll put a 30,
Yeah.
28.
Yeah. Yeah.
The 32 will be
No,
covering.
28.
28.
Or even 24. But anyway.
28.
Okay.
Oh.
So we are going to the diagonal now.
That
It's a
is why
fielder
I
wire.
wanted 20, that's why I wanted 28 here, then short that side. See there. Anyway, we'll go to D1.
So any our
Fluoro
question,
failed.
any our questions
Not working.
by our colleagues
Okay, good.
or any our audience?
Do you want to pre-dilate the diagonal lesion after putting the wire?
I think so. Because there is a 90% lesion, 85, 90%. So we have a 2.25 12 balloon.
Die.
And then we'll put a promus distal to the ostium. Good. Okay. Let's get the balloon. Yeah. Now, what is the COVID situation in India? They were like used to be 700-800 cases. Now they're creeping up to around 4,000 per day.
In Delhi, particularly, the number of cases are increasing. But in rest of India, not many cases are reported. But fortunately, so far, there's only positivity that's being seen, but no hospitalization.
Yeah, here, US kind of constant about
Okay, go up here. So you want to put a 225/16 stent?
okay.
Okay, down.
You have to pull back 2 millimeter.
Yes. Okay.
Good.
Looks like a soft lesion though, right?
Yeah. Okay.
Open. And also get us a 3028 Promus.
Yeah, so we are going to stent the diagonal separately first.
Stay away from the ostium, a millimeter away from the ostium of the diagonal.
Yeah. Okay, yeah. So this is the 2.516.
2 to 5.
2 to 5.
2.25, 16.
16 Promus.
I'd like to shoot it and see how the result is of the balloon is. I mean, optimal extension of the
Okay, we can show it. Just 1 second. Yeah, we'll just show the fluoro 1 second. Let's see how was the result.
Can you die properly?
That's okay, good. That's reasonable. I mean, it opened up. A young guy, I mean, even if it looks good. Now here, based on the data, since it's a small vessel, if you have a drug-coated balloon, could be okay. But as you know that we don't have a DCB in United States. Going up?
Yeah.
So this is the kind of case. PTC alone is not enough. If you want to do it, you do a drug-coated balloon. What would you do? Would you put a stent or drug-coated balloon or just PTC only?
No.
In general, we prefer to actually stent if it's about 2.25 and above. But the problem is that when you do a drug balloon, if we unfortunately die, there is a problem. Again, you have to end up doing something.
We have the LED stent.
Good.
Yes.
Good.
Right?
Good
Hold on.
result.
Yeah.
We are going to,
Yeah, that's fine.
Yeah, 3 or 28.
28 is good. So now we need to do, we have to kill some time, do the IVUS in the end.
Would have put the app
Yeah, a lot of
slides.
time.
No need.
And talk about some app or something then?
Yeah, but you have the wrong slides there.
No, but tell them to get the slide. Put this one up. What need to be done? I just put the guideline slide. If you had to be, tell somebody to go. We have some time, so we use that way. So we have at least 15 minutes.
Can you tell Andrew bring the app slides update or something?
Yeah. So we are going now.
If Andrew is listening, can he come down with the app slides?
And we'll then have some time, so we'll discuss about various new, innovative, new apps which are quite a bit become very popular at present, helping out in various issues. Good. Patient is very tachycardic. What's happening?
We are across.
Yeah.
Hmm.
Okay. Get the guide in.
I know 24.
No, what? Fluoro only. Let's see.
Wait. Okay, across.
No, but it cannot be across, right? You need to go a little distal.
No, cannot go in.
But you can have little distal room.
Okay.
Yeah.
That's too much.
So we have a 1 millimeter at the level of the diagonal.
Hmm.
Pull back and go back again. Yeah.
It's not allowing.
Good.
Okay, good. Now,
Many times when there is a little trouble, you pull back and go with the speed.
Okay, now die.
And we want to go after the diagonal. Okay, what is the pulse rate on this one? Can't even see. Huh? Take a picture.
Yeah.
92. Give 2.5 IV low pressure. Always keep a pulse rate 70 during PCI. This is very good. Remember, it's after the dot. Actually fit in very nicely 28 millimeter. Okay.
Stop.
And then you can go a little bit distal. 16 atmosphere.
Okay, down.
They like to see IVUS, I'm telling you. Will look good. Go 2 millimeter in. Go 2 millimeter in. Good. Good, good, good.
You didn't take the beta blocker this morning? Okay, ready? Okay.
Okay. What do you want to do? Post dilate?
I think
The
it
mid
looks
dilate
okay.
is definitely with the 3.25 to 15 balloon. Here is that a lot of the question is, do you do an image or you just do an angiographic guided intervention 3.25 and just to optimize your results. So that actually is the part of many other trials which are ongoing, and whether OCT or IVUS involvement. Here we are just going to go high pressure.
Still no stress, still no stress.
Would you image now in the end or OCT or IVUS?
You generally go ahead with OCT after implantation just to see whether we have optimally opposed the stent or not, and also whether we have landed in the distally into any kind of soft flake or any distal dissection is there. So normally we do at this moment some kind of IVUS and or maybe OCT and then see or result whether correct
No, we have to
position is
ask what percent they do. What percent of your cases you do imaging?
we are almost doing about 70% of the cases imaging OCT in our lab.
So more for optimization?
Optimization.
Good.
Yeah.
And also sometimes when we have a problem of diffuse disease, and also when you have it, the difference in the size of the vessels, we are trying to see the OCT and to approximately know what is the size of the vessel, and thereby looking at the size of the stent that we are using.
And go 2 millimeter further.
No.
Okay. So
Very
this
good.
is a 3.25
25.
15. Go 2 millimeter more. Yeah, here. That's it.
Okay, very good. Okay, down.
Dr. Sharma, do you use stent boost in your lab?
Yeah, we can use it. Put this one. Let's do the boost. Bring it. No, just put it there. Yeah, we're going to use a stent boost. Yeah, good. Yeah. Okay. Good. We have it. So we don't use much stent boost largely because of the radiation. But are we okay now? Good.
Yeah,
Let's
yeah.
go. Go. That's good.
Okay. This is not there, Pablo. Okay, good.
Actually, it looks very nice
Yeah,
on
we
the
don't
stent
need
boost.
anything.
All the stent boost, you see it on different side.
Can they get a stent boost on that? No,
No.
they can't see it.
They cannot, yeah. Okay, let's take a picture. We pull back. Get a Verapamil also. Take
Yeah.
a picture. Yeah. Good.
Give me Verapamil.
Yeah. Andrew, want to just connect there? Yeah. Good. And pull back the wire. Yeah. Okay. What do you think now?
Very nice result, actually.
Yeah, and the diagonal ostium remained the same. No problem, mild 10-20%. D2 is D1, I mean. D2 is completely fine. And
Is this a slow flow in the D1? I don't know. That's what I'm hearing. We must be.
you want to go to, we can go to some different view to see the ostium. Good.
Take a picture here. We can go to caudal, LAO caudal. LAO caudal showed it well.
Good. Okay. Screen down. Go to LAO caudal. Andrew is there. No, you need a little more caudal.
Okay, there.
Yeah.
Okay, center.
Perfectly fine. See that?
Yeah, excellent, excellent.
Yeah.
Keep talking. Let me see what he has.
Yeah. So key is that basically we have seen, optimized it, whether you want to do now the imaging, and so I mean again, a lot of people will go very high in imaging, and so we actually have our lab is always in the single digits in terms of imaging, and that to majority being the IVUS and some cases OCT. But we had a lot of OCT guided trials, particularly yellow and so, which is ongoing at present, even just completed actually, 130 plus cases, having a OCT, IVUS, all combined, and of course combining with our physiology. So we do quite a bit of physiological cases, guided pre, not post pre. This case was clear cut because of such a tight lesion in the LAD distally. Move this camera up and yeah, so they can put that camera. Yeah, good. So in this particular case, it was clear cut case of the, as you can see, the angiogram point of view, very high pressure and nicely expanded. So if what will be the region or what are the chances here further? You want to go ahead and do a more high pressure dilatation or do imaging, which will change. So we know that once you do imaging, you do more equipment will be needed. And if you are good trained with your IVUS, your kind of angiographic eyes, the short-term data like eye lumen 3 showed the minimum stent expansion was equivalent in the OCT guided versus angiographic guided. But OCT will pick up some more dissection and so that's for sure. So with that note, this is where we are. And now we wanted to just show Dr. Keeney another new app features which we have developed to help our interventionists on the new developments. Everybody has seen our bifurcate, octade, and the calcificate, and so. But now we have added new features, particularly from learning point of view, to all our viewers and learning more of the complications. People always say we learn more from the complications than the teaching of the guide wire, which guide wire to select. So, Anu?
Yeah, so just for this case, fluoro time was 11 minutes with a total contrast of 120 and air karma of 0.9. Yeah, where is the... So can we show those... they're going to... Now, any questions from the audience on the chat? We're good?
Very bad.
Hmm.
Yeah, okay, good.
So this is our original app actually was the bifurcate, which was an illustration. Then there was a lot of demand saying that can we do some animation and understand the various techniques. So most of these apps, you can see them on cardiologyapps.com. If you go to the website, you will see them, and then you are able to download by using either on the Google Play or cardiology apps. So how does bifurcate 3D work? So this is how the website is. So on the website, well, if you don't want to download it because on your phone, you can check on the website. So it goes as left main, non-left main by intervention. And then we also have some key important videos that we want to show. That would be there. Select the key videos. That is how it will look like. That if you want to go, this on the top is the animation that we would like to show. This is how the animation it is for a non-left main mini crush technique there. So if you see that these key videos can be just downloaded, can be used to understand, can be used for teaching purposes, lectures, any of those kinds. And you see side by side for every step. At the same time, we tell you what are the key features, how to do each step at a given time. This is the animation we have. This is the same thing again, that if you are choosing any technique, we are saying wire both main vessel, side branch, and whenever there is a side branch, and this is the discussion we had even in this case, that do we use a regular balloon or do you want to use a atherectomy? If there is ostial involvement, always try to use a atherectomy balloon. And then, you know, how you place a stent, wire comes out, then this is how you're doing the main vessel stent, recross, and do the final kissing. We are actually a proponent of no, proximal optimization in a non-left main. Left main, we know definitely you have to do a optimization. So if we are unable to, go into the side branch, see that we wired it but not able to go with the balloon, we are showing how you can do what is called as an anchor balloon technique. This is an anchor balloon technique that you go distal to the side branch, there you dilate the balloon, and then the side branch balloon will go forward. So this is everything has been shown. These are the other cardiology apps that are available, just to tell you how they came out and when. The first one was, I just mentioned, illustration bifurcate, which came out in September 2017. For imaging guidance, which actually is a OCT, we called as a octade. What we have there is interpretation of all the OCT images, and then we also have a quiz of a 60 question. We keep updating. We have 16 OCT cases, and we'll be adding another 5 to 6 cases this month itself. Then we came up with transeptate to understand, since we have to do transeptal in a particular way, just to do so many structural procedure, whether you're doing a mitral clip or we are doing left atrial appendage closure and all these things, where we know exact place where the transeptal has to be done. Tower cathode was an app to say how we will re-engage after the tower valve has been done, because that was a new challenge to the interventional attendings and us, is engagement of the coronaries after having a TAVR procedure, because we are now doing TAVR procedure in the intermediate and low risk patients who are younger, and we will be seeing them with years to come with some kind of coronary presentation, whether it's acute coronary syndrome or even if it is stable angina. Calcificate came out in 2019, management of calcific lesion. We are going to come up with a second version because we'll be adding IVL shortly for the Calcificate. Now Complicate is not, it's a web app where we have over 59 cases of all the complications that we see in the cath lab. So we have over 800 angiograms that we have discussed case by case, various complications that we see, and we describe each case, show the angiogram and management of each of this complication. Bifurcate 3D is something I just showed you, and the guide wire was the one that just came out in November last year. This is a description of over 150 coronary guide wires, microcatheters, and we have cases, or 25 cases saying which wire to be used for which particular case. I'm going to, is ready? Okay, just give me 1 minute. He's going to upload the guide wire. Why this is important is there's a nice robust search function on this that you can use it on the app or on the website, and there's a library that we have created of the various coronary wires, so people understand the property of each wire, so they know based on the property which wire to be used where. This is especially very important if you are doing a CTO, to understand which are the initial wires, the subsequent wires, what wire to be used for recrossing through the dissection and all these things. Is ready?
Yeah.
Okay, good. So this is the guide wire app, and all of them have app as well as a website, except for the last 3-4 ones. This has a website because the library is huge, and many people will say they don't want their to carry this on their phone, but many people would like to have it on the phone. And also all these apps are such that you don't need an internet connection, that you'll be able to easily see them without any of them. So CTO and non-CTO. So just going to show you, if it's a CTO, how we will go through various of these wires. Lesion based also we go through, and then calcific lesion that we have, properties of each wire. Now these are the various cases where I just mentioned. You can go learn through the cases, and this is the wire library where you have a nice search function. You want to search a particular wire and understand what is the property of the wire and where that wire should be used. You go to the search function, put the wire name, you will immediately be able to see that wire. This is just to show you the fighter wire made by different kind of various companies. So you can search based on the company, search based on the wire. These are the microcatheters, the various microcatheters that are available, that you can go through them. This is just another example of, I think, non-CTO lesion morphology. So what we are trying to say is, based on the lesion morphology also you can decide which wire you want to use. Brief description of the property of the wires that are important, how to use them in a particular calcific lesion. Yeah.
Any questions about, so this is wiring particularly, there is not much teaching on the wires, and this the wire app, it will be a guide wire app, is really tremendous and rapid, quite a bit of download because nobody.
You have the download, yeah. We have the highest downloads is in America. Next download is in India.
India.
Highest download is from India because of our teaching, and I think thank you to all the followers we have who follow us on the CCC live cases, learn from our web-based series as well as these apps. Yeah.
Thank you very much, Dr. Sama and Anapunakini, for a wonderful demonstration of excellent case. And I'll thank you very much for app also, because it's going to be extremely useful for those people who are actually learning and also doing routinely these cases, because many of us actually may not have exposed to many of the kinds of wires that are available in the market. And it's really useful to actually choose the right kind of wire in the right situation. And that's really useful. And I'm glad that you have put up in the, in for this kind of app, which is extremely useful for not only for those people who are already doing these things routinely, but also for those learners. Thank you very much.
Thank you.
Any other question, final comments, and before we complete our live transmission, and I'll go up to my room and you start your case discussion, and I'll join you in 2-3 minutes. Okay, if there's no more questions, thank you very much, and I'll see you shortly.